started the timer, and here is your question.
Okay, ma'am.
Right. If you have read and understood, kindly tell me, considering its surgical pathology station, how would you explain the pathophysiology of this condition?
Okay, ma'am. Regarding the case scenario, patient have adult polycystic kidney disease.
Okay.
The pathophysiology of the adult polycystic kidney disease, also due to mutation in the polycystin 1 and 2 and fibrocystin and nephrocysteine protein.
Yes.
This is protein responsible for to maintain the function of the cilia, essential to maintain differentiated phenotype of the tubular epithelium. Any changes in the mechanosensation by the tubular cell or by the tubular cilia and the altered calcium flux leads to changes in the tubular epithelial growth and the differentiation, leads to abnormal cell proliferation and fluid secretion, and abnormal extracellular matrix leads to cyst formation and the interstitial inflammation and the glomerular vascular damage. And also the pathogenesis of the cyst formation because of the cells of the tubular of the renal tubule defeated repeatedly, causing outpouching of the tubular wall with formation of saccular cyst. This the saccular cyst filled with the fluid derived from the glomerular filtration enter from the afferent tubular segment, leads to progressive expansion of the cyst separated from the alveolar tubule. This the isolated
Dr. Muhammad, network is bad. Okay. Can you please? Network is really bad. Okay, can you please tell me what would be the gross finding or the gross pathology you can tell in this condition? Can you please tell me what would be the gross pathology that you'll notice? Yes. Yes. Can you name few other organs in which there is formation of cyst as well? Can you name few other organs or other conditions?
Hello?
Yes. Can you name few other conditions or organs in which you can also see cyst formation?
Yeah, can be also the cyst formation and the liver and the
Yes, liver, ovaries, pancreas, and spleen. Your voice is gone again. Can you please tell me the complications which are associated with this condition? Can you please tell me the complications associated with this condition?
Yeah, complication, renal complication and extra-renal complication. Could be renal complication and extra-renal complication. The renal complication could be renal failure and the infection and renal stasis and renal stone and extra-renal complication as brain aneurysm and the mitral valve prolapse and the cholelithiasis and the cholangitis and the portal hypertension.
Can you please tell me what is the mode of inheritance of this condition?
Yeah, mainly autosomal dominant in the adult polycystic kidney disease and the autosomal recessive in the infant polycystic kidney disease due to mutation in the polycystic kidney disease 1 and the polycystic kidney disease on the chromosome 16.
Okay, good. Can you please tell me what is the difference in polycystic kidney adult disease and the polycystic kidneys disease in children?
Yeah, the adult polycystic kidney disease autosomal dominant due to mutation in the polycystin and the polycystin 1 and the 2 protein, and the infant polycystic kidney disease autosomal recessive due to mutation in the fibrocystin protein, and can be discovered infant polycystic kidney disease as during the pregnancy by the ultrasound, and the manifestation presented with renal failure at the infant age, and the adult polycystic kidney disease presented with the renal failure and hypertension, undiscovered hypertension, and could be myocardial mitral valve prolapse and the aneurysm and hypertension,
Yes.
and can be presented with subarachnoid hemorrhage.
Yes. Can you please tell me why this patient experiences pain, abdominal pain?
Okay, because of the enlargement cyst leads to stretch of the renal capsule by enlargement of the cyst, and could be due to dragging of the enlarged cyst open it is the pedicle.
And the why patient has raised parathyroid hormones and fall in 125 dihydroxy vitamin D levels?
Yeah, because of the F23 fibroblastic growth factor 23. This is protein synthesized by bone and bone cells, and the membrane protein expressed in the kidney and the parathyroid gland can be cleaved and released into the blood cells and act as a phosphoturic hormone, increase the parathyroid hormone, and suppress the synthesis of the vitamin of the active form of the vitamin D.
What should be the management that you can offer this patient?
Yeah, the management need full history and the examination and the investigation and the treatment after empty meeting, and the management could be control hypertension, can be give the patient angiotensin convertase enzyme inhibitor and treat the infection and treat and the patient need the CT scan to exclude aneurysm and MRI, and after communication with the neurological consultation and the cardiovascular consult and the nephrological consult, and the treatment could be an option, another option, nephrectomy.
Okay, right.
And the kidney transplantation.
Transplantation. All right.
And kidney transplantation.
Yes. Can you please tell me some differentials that you'll consider in this condition? What differential diagnosis would you consider?
Yeah, another differential diagnosis could be simple cyst, could be sponge kidney disease, could be von Hippel disease, could be tuberous sclerosis.
Okay, you did say the one last option could be the management as transplant. So can you please, what type of grafts or what type of graft rejections can you expect if renal transplant is done?
Yeah, the types of the graft rejection could be hyperacute and could be acute and accelerated, and
Yes.
could be chronic.
How would you differentiate among them? Which one is hyperacute, acute, or chronic?
Yeah.
Yes, how would you know?
The hyperacute D2 presence of the recipient antibody against the donor. Yeah, hyperacute D2 presence of the recipient antibody against the donor tissue occur within minute following the transplantation due to activation of the complement and the clumping of the red blood cells and platelets leads to interstitial hemorrhage. The kidney becomes swollen and discolored. The treatment nephrectomy, and the acute rejection classified as accelerated if they occur in the first weeks, and the acute if they occur within first 100 due to T cell mediated with the lymphocytic infiltration and the tubulitis and the arthritis, can can be treated with the high dose of the steroid. And the chronic rejection occur from 1 to 2 years after transplant due to humoral system and the graft fibrosis and atrophy and atherosclerosis in the chronic graft rejection.
Okay, Dr. Muhammad, just suppose you have gone through the renal transplant and patient after renal transplant does not feel good, and you realize that patient is on immunosuppression medications, and you realize
Yeah.
that there is malignancy being formed. So
Yeah.
what type of malignancy would you expect in these sort of patients?
Yeah, squamous cell carcinoma of the cervix and the skin, basal cell carcinoma, Kaposi sarcoma, and lymphoma.
Yes.
And the lymphoma.
Yes,
And the Kaposi
lymphoma.
sarcoma.
So how would you suggest that this complication of carcinoma should be managed? This complication of carcinoma, how would you manage this situation?
Yeah,
What would you do?
The treatment need excisional biopsy and send for histopathology, and after that communication with the
You'll remove, yes, you'll remove
can
this.
be decision
You'll remove the
the
graft.
treatment according to the stage of the tumor.
Yes, but the graft will be removed first of all. Okay, can you please look at this
Yeah.
and tell me what are you looking at, please? What is this?
Okay, mom. This is enlargement of the kidney with multiple cyst formation in the kidney.
Yes. Yeah, possible adult polycystic kidney disease.
Yeah, characterized by cyst filled with the fluid and the hemorrhagic cyst.
Yes, these dark ones. Okay, good. Thank you.